This is talk number 2 in your syllabus. For those who, it's not acute kidney injury, but it's the second talk, and Dr. Waker and I switched. So my talk, over just 30 minutes, very brief, is to give you all the information you need to know about chronic kidney disease. And I'm going to do this in the form of a story about a 78-year-old patient of mine. And I've kept updating this story of the 78-year-old with more and more evidence about how to treat patients with chronic kidney disease. And in fact, there are even some updates that I will share with you at the very end that are so exciting that they haven't yet been published, but you'll see them and you'll start using these sort of treatment strategies. So this is the history of this patient. This is a 78-year-old African-American man with type 2 diabetes and hypertension. Nowadays, type 2 diabetes is almost an epidemic in almost every country, not only in the US, but in the developing world and many other parts of the world that are fully developed. And people have speculated as to why that is, but most likely this reflects a combination of genetics, lifestyle abnormalities, the emergence of sort of fast food in everything we do, obesity, a whole host of issues that come with what we call development. And so there are millions upon millions, hundreds of millions of people around the world now with type 2 diabetes. And so and a number of these people will develop complications of CKD. And this man comes to see us with type 2 diabetes and hypertension. His creatinine is 1.32. But when the GFR, the estimated GFR, which is based on a prediction equation, an equation that calculates based on a number of factors, is reported, and almost now every place in the United States and elsewhere has not only the serum creatinine reported, but also the estimated GFR reported. His estimated GFR is greater than 60 mils per minute per 1.73 meters squared. Some of you probably wonder, why isn't it more precise? Why doesn't it say 62 or 64 or whatever? And the reason for that is that the equation that's used commonly, the MDR equation, loses precision above 60. So that's why they just report it as over 60. There is another equation called the CKD epi equation where you can get more precise notations above 60, but you have to know that that's the equation that's being used. As I said, most equations currently in most of your laboratories that report results are the MDR equation. Anyway, this chap is healthy. His past medical history is that of hypertension, which he's had for around 15 years, type 2 diabetes for around 8 years, and he's got some cholesterol issues which have been treated with atorvastatin. His blood pressure at various points have been in the 150 to 160 millimeters of mercury range for his systolic. And his medications have included lisinopril, aspirin, hydrochlorothiazide, atorvastatin, metformin, and glipizide. And this phenotype of this type of person is, I'm sure, very common. I'm sure many of you see this type of patient all the time in the office, right? And the question that's asked here is, does this person have chronic kidney disease? Because he has a serum creatinine of 1.3, which is slightly above the normal range, but his GFR, estimated GFR, is more than 60, greater than 60. And so that's your first question. Now, as you go through the physical examination, there's nothing really remarkable. His blood pressure is a tad elevated, more than a tad if you use the latest guidelines, but 152 over 68. His dipstick urine shows trace to 1+ protein, but is otherwise negative, and his creatinine is 1.3. He's got a hemoglobin A1C of 7.8. So the question is, does he have kidney disease? And the reason you ask this question is that if this chart of normal people, right, so these are normal volunteers, and you go from age 20 to 90 in age, and believe it or not, there are lots of people now living over the age of 80, and many of them come and see you regularly. You can see that GFR has, or kidney function has, as this is measured GFR, has an interesting trend. After the age of 45, your GFR starts going down about 1 cc per minute per year. So even you guys sitting here in this room for 8 days, you're going to have a slightly lower GFR when you leave. Sorry about that. It's one of those things. But this is the GFR, so up to around 50. And you know, the interesting thing is, many other aspects of you are declining also in the same sort of pattern. So don't blame the kidneys alone. But the GFR is declining, and so by the time somebody's in their 80s, if you look at the 95% confidence interval, so most measures, you see that there are people who have normal kidney function, who are otherwise normal, who have GFRs that are in that range, right? And so if you see an 80 or 90-year-old with an estimated GFR of 69, 60 even, it doesn't necessarily mean that they have kidney disease, right? And a number of years ago, there were people, the nephrology community came out with this idea, we shouldn't be dialyzing unhealthy people. This idea of healthy start dialysis. So an older person comes in, you measure their GFR, it's like 15, well, that's the time to start them on dialysis. And tens of thousands of people in the United States, little old women and men with not much muscle mass, ended up getting started on dialysis, which probably wasn't necessary. Because the person was otherwise healthy, they were probably going to die from cardiovascular disease before their kidneys fail and they get on dialysis. So don't over-treat people, and remember that kidney function has this rate. The good news for women is that their GFR declines less fast than men does. So men's GFR declines at a faster pace after the age of 40. Some women think that other things around men also decline very fast after 40, but we'll leave that for another discussion. But you see, women's GFR tends to decline. So the decline starts later in life, and the decline tends to be slower, whereas in men, the decline starts in their 40s and tends to be steeper after 40. All right? And that's an interesting thing to keep in mind. The other thing you should think about when you think about whether somebody has kidney disease is, does this person have risk factors for kidney disease? Because kidney disease is going to occur in the same neighborhood as other things. Does he have diabetes? Well, for this gentleman, the answer is yes. Does he have hypertension? For this chap, yes. Does he have older age? Yes. Family history of CKD, people who have a family history are more likely to have CKD themselves. Turns out racial and ethnic minorities have higher levels of CKD. We'll come to that in a second. But these interesting factoids, risk factors, are important as you consider whether somebody who's older with a GFR that's borderline actually has kidney disease. This just shows you the relative risk of kidney disease among minorities compared to whites. And so African Americans have a 4.5-fold higher risk of kidney disease. That's pretty staggering. Native Americans, 3.5 times. Asians, 1.6 times. Latinos are also a 1.6 times greater rate than the reference white population. So if you see somebody who's an African American or Native American or an Asian or somebody, a Latino, think about the fact that they're more likely to have kidney disease than your average white person. The other thing you can do is in somebody like this, you can obtain lab data. I know nobody likes to do urines anymore because most people in their primary care practices think the looking at the urines are just completely useless and it just messes up your back room and you don't make any money out of it, and there's lots and lots of reasons you don't do it. But actually, it's not a bad idea to be able to have a little microscope at the back. Okay, if you do it, you can bill about $15, which is not so bad. That's okay. Nowadays you don't get paid $15 for many more sophisticated things you do. But you look at the urine, if you do spin it, and in people with kidney disease, the urine is often not normal. You can see these hyaline casts, which are broad. And so here, it's not easy to see, but you can see there's a sort of faint. These are hyaline casts. They look completely benign, but when they're big and there are many of them, that can portend of someone having actually something going on, kidney disease. And when these casts have these fractured looks to them, they're called waxy casts. And these things are features of people with kidney disease, chronic kidney disease. And they tend to be wide because these casts come from TAM horse fowl protein, which is sort of leaks out into the tubules, and these casts form in the tubules, and if the tubules are dilated, which they often are in people with kidney disease, these casts tend to be wide. You can do a renal ultrasound. Let's accept the fact that you don't want to get into the messy business of urine analysis, but you can request a kidney ultrasound. And a kidney ultrasound is non-invasive, and usually what you will see is you'll get the size of the kidneys. And people with chronic kidney disease tend to start shrinking their kidneys. And the radiologist will say, the kidneys look small, right? That's important information. And they'll tell you that there may be cortical thinning. The cortex is where is the business end of the kidneys. That's where all the filtration occurring. The GFR is being generated from the cortical end. So they'll tell you the cortex is narrow, and that will give you some indication that this person has something that's been there for some period of time. So it also gives you insights into the fact that there's some chronicity to this chronic kidney disease. It's also useful to look for proteinuria and albuminuria. And again, I'm conceding that you may not want to dip the urine, but if you decided to dip the urine, or your lab assistant decided to dip the urine from these Bayer multisticks is what we mostly use in clinic, will look for protein in the urine. And they only become positive when there's significant protein, but they're not accurate because it depends on how concentrated the urine is. Somebody's come in from a hot jog outside, the urine is going to be concentrated and you'll pick up even small amounts of protein. But someone who's been drinking lots and lots of water, you're not going to pick it up. But it does indicate what's going on. A much better thing to do is the albumin-creatinine ratio. And the albumin-creatinine ratio is a spot ratio, and you just check a box off on the lab request form, and they'll go out into the lab area, and they'll give a little bit of urine, and all that happens is the spot concentration is calculated by the lab, and they develop a ratio, the ratio of the protein or albumin to the creatinine. And that almost always correlates with roughly how much protein there is in the urine. There is really no need to do a 24-hour urine. I mean, I have a nephrology practice. In the last 5 years, I've done a 24-hour urine maybe once or twice. And usually I do it for people who are patients who are a pain. So just as a punitive measure, I'll tell them to collect a 24-hour urine, because you have to collect the urine, you have to put it in your refrigerator. Most people can only do it on the weekends. It's a sort of a nasty thing to have urine sitting in your refrigerator. And so if somebody's been extraordinarily painful to deal with, I'll tell them to do a 24-hour urine. I'm just joking before you write in a complaint. I'm just joking. But you should not be doing 24-hour urines, almost in anybody, except for people you're evaluating for kidney stones, where it's actually important to do a 24-hour urine. Everybody else, virtually not necessary. A spot albumin to creatinine ratio, spot protein to creatinine ratio is perfectly reasonable. And it'll tell you whether somebody has normal albuminuria, microalbuminuria, or macroalbuminuria. And microalbuminuria is not small albumin, it's just small amounts of albumin. And so anybody who has 30 to 300 milligrams of albumin to a gram of creatinine, so standardized, has microalbuminuria. Particularly important for a person with diabetes, because the American Diabetes Association tells you to screen these people after 5 years of having developed diabetes, and so it's useful to see whether they've developed microalbuminuria. The other thing is, you can use albumin to give you some idea whether this person has any risk. So if this person, our patient, our 78-year-old, had no albumin or protein in the urine, even if his kidney function is borderline, you don't need to go any further. He's essentially normal. He's not going to progress. He's going to sit there. And this is what happens in very older people. They have depressed GFR, but they have no albumin or protein in the urine. They're going to do just fine. But if they have albumin, then you can see that you can risk assess them. And if they've got microalbuminuria, they've got moderate risk of progression to end kidney failure. If they've got a lot of albumin in the urine, they have a lot of reason to progress to kidney failure. That's important to know. The third thing is an innovation that I think we've learned as nephrologists from cardiologists. So nowadays, most cardiologists, at least at our hospital, have a little piece of a card which has the risk equation, you know, the Reynolds risk or the Framingham risk equation, and they're going around and seeing what's the risk for this patient and deciding whether to treat their lipids or whatever. Well, we actually now have a kidney failure risk equation, and it's worth using this. You just go online and go for the kidney failure risk equation. That's what you put in Dr. Google. And this is a laboratory-based equation that predicts kidney disease progression. Because isn't that what patients want to know? Isn't that what you want to know about your patient? What's the likelihood this person's going to develop kidney failure? Is it high likelihood in the next 3 to 5 years, or is it very low likelihood? And so this allows you to accurately predict CKD stage 3 to 5 progression over 5 years. And there are different variable kidney failure risk equation. You can use whatever you want. Usually the 3 variable is good enough, and it just requires age, sex, and eGFR. Most people in medical school and you're doing a residency think of kidney disease as a monotonic process. Once the kidney function starts to decline, it's never ending. That's actually what most people's views are. And so you just, you draw a curve and you say, well, this person's declining at 3 to 5 mils per year, so that means by the time they're 45, this person of mine will have kidney failure. The reality is that's not true, and in fact, what studies have shown is kidney function declines very differently in different people. And so not only do you need to know the risk failure equation and what's the likelihood of that person declining and how fast are they declining, but you also want to monitor how that decline is happening, because if you start with someone at the very beginning and you haven't monitored them, you might think that they're going to be declining at 2 to 3 mils per year, and you'll be very concerned, and you might see them every 3 to 6 months. But if you monitor them for the 6 months to a year and there's absolutely no decline, that should be reassuring. That person might be in these blue curves. They're either not going to decline, or they might actually get better. Or they may be people who decline initially, decline initially, get better, and then start declining very fast. And this is an important issue to keep in mind. Make sure you monitor kidney function over time in your patients. Okay, so you've done all of that, and the next thing you have to do is to say, well, what do I do? And there are certain things that you need to worry about, which are progression factors: a higher level of protein or albumin in the urine, high blood pressure, poor glycemic control, whether the person smokes, what their lipids are, and whether they're taking drugs, whether these are illicit drugs or even non-illicit over-the-counter drugs like non-steroidals. And you have to manage these things, and most of these things are not managed by a nephrologist, they're managed by primary care docs and family practice. So in this person, does he have CKD? The answer is yes. He has risk factors. Ultrasound actually showed a little bit of thinning of his cortex and smaller kidneys, and he had protein in the urine. So what are the next steps? So the keys now to managing the CKD are shown here. The most important thing, arguably, in anybody with kidney disease, the one thing that we do the least well, whether it's patients seen in primary care or in nephrology practices, is manage their blood pressure. And that's not because of negligence, it's because it's really hard. Managing blood pressure in patients with kidney disease is an imperfect art, even today. And so if you're struggling to do it, don't be alone in thinking that you are being singled out. Everybody has a hard time. Likewise, diabetes is hard to manage, right? The guidelines are pretty clear, but getting hemoglobin A1Cs among patients to that level is often challenging. The key things, in addition to bringing the blood pressure down, and I'll talk about that in a minute, is to use ACE inhibitors or ARBs. ACE inhibitors or angiotensin receptor blockers for blockade of the renin-angiotensin system. For those who are registered for the lunch, you'll hear from an iconic figure, Barry Brenner, whose work over probably 5 decades put the whole use of ACE inhibitors and ARBs on the map. And more recently, he started to publish work in SGLT2 inhibitors for type 2 diabetics, where these new inhibitors are being increasingly demonstrated to show that they retard progression of kidney disease. So absolutely, if somebody has kidney disease, not a diabetic, you want to have ACE inhibitors or ARBs. If they're a diabetic, type 2 diabetes, an ACE inhibitor or ARB, and you're thinking about their candidacy for an SGLT2 inhibitor as well. You might consider other interventions such as low-protein diet or statins, and these are things that are going to be dependent on a variety of factors. Nowadays, statin therapy is usually governed by what their level of risk is on a risk equation, a cardiovascular risk equation. Low-protein diet, usually you have to weigh in what the person's nutrition is like, but most people, I recommend that they go on a relatively low-protein diet, a Mediterranean diet of fresh fruit, vegetables, grilled food, avoiding meat, and that's usually the recommendation. So it's a moderately reduced diet. ACE inhibitors and ARBs and calcium channel blockers are what you're going to be treating these patients with for their blood pressure and for managing progression. ACE inhibitors and ARBs have similar antiproteinuric effects, and the combination of ACE and ARBs do reduce proteinuria significantly, but they are not recommended to be taken together. So dual blockade is not recommended. And this is an important board question that's often asked. Calcium channel blockers are also really important. They're the bread and butter of managing hypertension in patients, great for managing systolic blood pressure. There are two varieties, as you know. There's dihydropyridines and non-dihydropyridines. The dihydropyridines, like amlodipine, are the ones that you should be using. These are very effective agents. They don't affect kidney progression, and they don't affect proteinuria, but they reduce blood pressure very effectively and are usually well tolerated. Although about 15% of patients treated with amlodipine will develop a little bit of lower extremity edema, and you should warn patients about that, because like the possibility of some dry cough in patients with an ACE and an ARB, about the similar proportion will develop this little bit of edema, always reversible. It's not the same segment of people who develop both. It's just that they, if you have patients, they'll develop, there's a significant possibility they might develop. The non-dihydropyridines like diltiazem reduce some albuminuria a little bit, not very effective as blood pressure agents. Some people will use dihydropyridines and non-dihydropyridines together to enhance both blood pressure reduction and reducing proteinuria. I tend not to do that, because diltiazem is not really a very effective blood pressure lowering agent. There's some fairly robust information about why dual blockade should not be used. I'm not going to go into the literature in any detail. This is now in your syllabus, but there's a paper in the New England Journal of Medicine in 2008 called the On-Target trial, which showed that in 25,000 patients treated with either ramipril and telmisartan or both, there was no benefit of cardiovascular endpoints with the combination therapy, but there was a trend, in fact, to increased risk of death. And the patients on combination therapy had many more side effects like hyperkalemia and drop in GFR and so on. So there's good evidence from large studies suggesting that dual blockade is not the right way to go. And then a sub-study of that showed that in fact patients, 5,000 patients treated with the combination had worse renal outcomes. So if you're trying to reduce progression with an ACE or an ARB, and you use both an ACE and an ARB, and in fact they get worse progression, it's like no good deed goes unpunished. You don't want to be doing combination therapy. Nonetheless, patients do require multiple blood pressure agents, and this is just a summary slide showing that in most studies, in diabetics and non-diabetics, treatment of blood pressure requires usually around 3 to 4 agents. So if you're not getting your blood pressure down in a patient with CKD, that's because you may not be using enough agents. You need to use them optimally, and you need to use multiple agents. The JNC8, which is the latest guidelines from the Joint National Commission, will tell you that the blood pressure goal should be less than 140/90. And if the patients have CKD, you should be using ACE inhibitors, ARBs, or calcium channel blockers, or thiazides. This guideline is now very controversial because it seems to have been superseded through recent evidence and new guidelines with a much more aggressive approach towards the treatment of hypertension, including perhaps those with kidney disease. And in fact, this is the latest ACC guidelines were just presented this past year, and it's redefined normal blood pressure as a blood pressure of less than 120/80. Anybody with a blood pressure of greater than 120/80 is viewed as having either pre-hypertension or hypertension. So 30 million additional Americans have been added to the segment of population that has hypertension, 30 million people, right? And so normal blood pressure is now defined as less than 120/80, and that should be the target in most people, including those with kidney disease, although, as I said, there's controversy in this area because the other guideline committees have not kept up. So some kidney guideline committees and diabetes guideline committees are still in the gray area between 120 and 140, so 130/80, and that's confusing for most people, including someone like me. For someone less than 120/80, that's normal blood pressure. You just promote optimal lifestyle habits and they should be fine. For people with hypertension, in addition to non-pharmacological therapy like reducing salt in the diet, isn't that a simple thing, right? Just telling people don't eat food where you're adding additional salt or wean yourself of additional salt. But then the other recommendation is that in order to think about how to treat, you should do a cardiovascular risk assessment using one of the calculators like the Reynolds or the Framingham, and then decide on how aggressive you need to be. And this paper in the New England Journal of Medicine, published a few months ago by George Bacris and colleagues, made the point that these new updated guidelines from the American College of Cardiology are not based on randomized controlled trials, and that this new guidelines updates JNC7 but not JNC8. That adds the confusion. So you have this progressive updating of guideline JNC6, 7, 8. The ACC comes and they update 7, so now there's JNC8 and there's updated JNC7, which is the new ACC guidelines. Very confusing. But the key thing out of it is that it integrates cardiovascular risk assessment into blood pressure management. It does keep the BP goal the same as before in patients over the age of 65. The other interesting, important trial that you probably need to be cognizant of is the SPRINT trial. SPRINT doesn't apply to the patient that I've been talking about because our patient is a diabetic, and SPRINT excluded diabetics. And I'm going to go through these slides very quickly because they're just put there for your reference. But this trial of over 9,000 patients was a landmark clinical trial that showed that aggressive lowering of blood pressure in patients reduced cardiovascular mortality by about 30%. That's unbelievable. There are very few trials that have shown that ever. That much of a reduction in risk, and here they were talking about mortality and cardiovascular mortality. The really new class of agents on the block, which you really need to know about because you will be seeing lots of people with chronic kidney disease and type 2 diabetes, are SGLT2 inhibitors. And SGLT2 inhibitors are basically agents that act on the kidneys. So the kidneys have gotten into the business of regulating blood sugar and blood pressure, right? And the way this works is that in the kidney, in the proximal tubule, you have SGLT2, which is in the early part of the proximal tubule, and SGLT1, and these are channels that allow passage of or regulate how glucose is managed. And if you inhibit SGLT2, you open up the gate for glucose to be wasted by the kidneys. So isn't that a novel concept? You're eating all this glucose and you take a medication that basically allows you to waste glucose and the blood sugar comes down. And with glucose goes sodium, so blood pressure goes down. And so these agents are very exciting agents. They work. They reduce the hemoglobin A1C in most diabetic patients who have a hemoglobin A1C of between 7.5 and 8.5 by about 0.5 to 1.5% in terms of units. They usually associate weight loss, usually loss of, because of salt and water loss, a reduction in blood pressure, and they're usually very well tolerated and really very effective. And recent data presented just recently, hot off the press, from studies that are currently coming to completion suggest that in the future you're going to be able to use these agents even among patients who don't have normal kidney function. So even patients with depressed kidney function, these agents are going to be usable. Right now the label says you shouldn't be using these agents in people with chronic kidney disease, but increasingly now, evidence suggests that they are safe even among patients with reduced kidney function, and I'm sure the guidelines will change in the near future. This is a paper in 2016 published by Christoph Warner as an analysis, and they use empagliflozin and the progression of kidney disease in type 2 diabetics, and they analyzed 7,000 patients worldwide. And here patients had GFRs of greater than 30, so people with chronic kidney disease, and they use empagliflozin, an SGLT2 inhibitor, or placebo. And what they found was a nearly 40% reduction in the worsening of nephropathy, 40% reduction. 44% reduction in doubling of serum creatinine, and a 55% reduction in the initiation of renal replacement therapy. And the figure to see is here. So these are patients on placebo, and you see there's a progressive monotonic decline in kidney function measured here as eGFR. But when you treat patients with empagliflozin, there's a slight initial reduction and then a flattening and a stabilization. People in the placebo arm are heading to dialysis. These people are stabilized. So this is a class of agent that's going to be part of your toolkit in managing these patients. So in summary, our patient, the 78-year-old person, has lots of options available, lots of issues to consider by you in managing, and most of these things are going to be managed by you, not by a kidney specialist. You want to be using GFR equations and albuminuria to make a diagnosis of CKD, do an ultrasound to assess kidney size. I would recommend now using a kidney failure risk equation to at least give you some idea of what the likelihood of progression is going to be over 3 to 5 years. Use an ACE inhibitor or an ARB, but not in combination. Consider adding an SGLT2 inhibitor for type 2 diabetes. And increasingly, the evidence points to your ability to use this among patients with CKD. Although right now, the recommendations and the label says modest to well-preserved GFR. So just wait for a little bit, but the guidelines and the label, I'm sure, will be changed. And remember, use multiple agents for blood pressure control. Thank you very much.